do that. I'm not saying that I do think there is the opportunity to put local flavor on national trends, but that is a trend, and I'm sure the primary care guys have agonized about what's the right thing for them to do, to be on call or at the hospital making rounds, or should they be in their office? But that's my read on that.
I'd like to speak to that. The problems that we started seeing, in my opinion, occurred with the general public's unhappiness with the hospital's program. I know some of those hospitalists, they're good physicians, but for whatever reasons, they have not been a good fit for our community. And I think this is one point where the local hospital could make a lot of difference in the satisfaction of you as the patient and the healthcare consumer. If they took all of the great doctors that they currently employ and they asked them to work shifts and do their turn as a hospitalist provider, I believe that our community would come back to our hospital in droves, because our local physicians that built this community are really excellent at what they do. I was privileged to stand beside them in the ICUs, in the emergency room, in the step-down units, and on the wards, and I missed them terribly when they left. So I think that our local hospital, if our board were really, really interested, and I'm hoping they are, in trying to provide the best service and the most comfortable service possible, they will do what other communities have done across America. Some of them have actually rejected this national trend, and they've requested that their local physicians come back into the hospital, and they've paid them well to do that. And with as much monetary base as our hospital has, there's not any excuse why they cannot pay our local physicians to become our local hospital.
That answers part of the next question, except at the end it says, and who decides about releasing them from the hospital?
Well, I mean, that is something that should be a mutual decision. Although we understand that there are a lot of drivers that determine when you're discharged from the hospital. When you come into a hospital, you come in under a disease-related group, a DRG, and everyone that works for the hospital on the billing side understands that, let's say, for instance, the most expensive DRG in America is congestive heart failure. If you come in the hospital, you're labeled as congestive heart failure, your hospital is going to get so many dollars to take care of you. There's a bad part of that. If they get you out of the hospital earlier, the hospital makes more money. If you stay longer, the hospital loses money. So it's a give and take, and it's a balance. But there again, if you have people that you know and love and understand you and know your history, etc., you can usually strike a comfortable decision that benefits you. So there again, we think that that very important input has been taken out of the formula here in Glasgow, and we think we can get it back in. But you guys are going to have to help us do that.
This may be just a yes or no answer. Were any local physicians considered or approached as possible hires for the hospitalist positions?
I'm not aware of that.
I don't know that
at all. I don't know that.
Now, this could easily have been a panel of a lot more people than us. Well, I don't know all these answers, and she won't know all of them. But as we said, some of the people who could have answered them didn't really feel comfortable being here. So.
And some of them were asked, and many of them approached us and said, for instance, they did not feel comfortable signing a letter that you guys saw in the newspaper. I got many phone calls about that, and I told them, do not worry about it. We understand your predicament. We love you. We appreciate you. It'll be okay. Do you know the answer to this? Go ahead with that question.
Okay, next question while they look at that one. What are the differences between the hospital parts of A, Glasgow TJ Community Hospital, and B, TJ Partners, and what are the possible impacts, positive and negative, to our city, county, and school systems due to the hospital property investments and monies profited, that is, taxes from these incomes?
Well, again, I don't intend to make you think I'm an authority on it, I'm not. But the hospital is a non-profit entity. And when the hospital buys a piece of property that yesterday was a property tax generating piece of property, tomorrow it's not. So that does affect the tax basis on the property tax issue. Compensatory, I suppose, would be the fact that the hospital is the largest employer, I think, in the community with about 1,200 people. So they're an occupational tax producer, but what that asks about is the erosion, if you will, of some of these taxes, school taxes and property taxes, and that is an issue.
And we were told by some local folks who know about these things, I certainly don't, but I learned a lot in the last 2 or 3 weeks getting ready for this meeting, that the city of Glasgow has lost about 160 to 180,000 per year in property tax, and the county's lost about 400,000 a year in property tax because of that not-for-profit stance. So there was some mention made that the hospital could be approached to make an in lieu of tax donation that would greatly offset those losses. I mean, it could completely offset those losses and help our kids and our school systems and folks that really need that cash flow. So.
Now, the lack of transparency is an issue. The number DT made reference to was obtained in a 990 form from 2009. At that time, the hospital had $50 million in cash with a pipeline of accounts receivable of about $20 million. I'm sure that's not the same today, but I don't have those numbers for 2011. But the point is, it's a financial monster that can help you or can crush you. It's a big ordeal. It's going to be interesting to watch out of the corner of your eye the Supreme Court decision on that deal in Albany, Georgia.
The next question has to do with the comparison of the new facility being built versus upgrading bathrooms, etc. at our community hospital. Will there be a plan to continue to upgrade the community hospital, TJ?
We're the wrong people to ask. I don't know. Okay. I mean, it's a good question, but there's an example. I think and you deserve some clarification, but the way to get it, I'm sure is of interest to many of us, but the way to get it is to become a part of one of these teams, and that question would certainly be an appropriate one for either of two of those. Either the board could clarify that, or the team dealing with civic issues, how this affects the community at large. I think that's an appropriate question.
Next question has to do with the number of years that was published in the paper concerning the 60 physicians supporting the partners, and just wanted to make us aware that if we listed each one of those individually to see what that would be on an individual basis. So that's just information kind of question, I believe. Okay, here's a good one. We've all asked, why are several of our doctors leaving our area at present, do you believe?
Well, I would just like to speak to one particular physician that I really miss on our staff, and that's Dr. Anna Call. Anna was an excellent pulmonologist. She had come to help Dr. Elgin Dickinson, who's been a fabulous pulmonologist and needed help at that point in time because we have a lot of pulmonary disease in this area. And Anna made a simple request to our administration, and that was to be able to report directly to the CEO instead of report to some other individuals. She opened our sleep lab. She was there day and night helping our patients. She was gracious, she was intelligent, and she was committed. She was competent. And because she was the very first strike against our medical staff, in my opinion, she tried everything she could to try to make a comfortable existence at our hospital. She was ostracized and made to feel that she did not belong. And it was not the medical staff. We actually put our arms around her and we tried to help her to stay. report now that she's now living and working in Arkansas. When she walked into that hospital, they opened their arms to her, and about a month or two later, she called me and said, I opened my office today, there was cherry furniture. I couldn't believe it, and a note on my desk that said, and let me know what else you need. I'm jealous of that community. I loved her, she was wonderful. And that didn't happen.
Well, I'm losing a good friend and a good teammate and a great orthopedic guy. And you'll be the team that suffers that loss with me. He and I were, I'm trying to tiptoe lightly here. He and I we felt justified in pursuing some compensation for taking call. When we take call, our name goes on a list, and then we are accessible not only to our own emergency room, but outlying ones. It depending upon what specialty you're in, where that circle lies. If you're a cardiologist, they may have a cardiologist in one area, but they may not have an orthopedist, or vice versa. And if you're a urologist, you may not get patients from Russell County, for instance, because there's a urologist in that area, but there's no orthopedist in that area. So, and we've gone there for 20 years. So, for me, for us, we serve Glasgow, Caverna, Russell County, Greene County, Columbia, Clinton County, Cumberland County, Wayne County, a little bit of Casey County every now and then, a little bit of Allen County. So we've got about 10 emergency rooms. So, and we've served those areas for 20 plus years. And but where do those people come when someone broke a hip in Cumberland County? Well, we bring them here. So someone might say, well, that's just business for you. It is business. But I am accessible and need to be accessible. And it's the same for general surgeons and everybody else. But the trend, we're always told medicine has changed. Well, we agree, it has changed. And I don't mean to get into all this, but it has changed. That's what's told to us when we're told we've got to swallow this bitter pill and medicine's changed. And we thought, you know what, medicine has changed. This is what's happening in other communities. People that do what I do and people that do what she does are compensated to be available. But our team said, no way. You have to like it or lump it. And that was not an easy pill for us to swallow. We had no choice. That was the deterioration of the local support. That wasn't the issue that I just mentioned, but it was an example of what was going on where that began to be a concern. But Matt's got 2 children, and his wife's quite interested in lots of things, library. He just saw the future elsewhere as a little more stable than what we have here. So, agonizing decision for him, and I hate it for me, and I lost a friend. These guys lost a neighbor, and we really lost a great member of the community, he and his family. So that's kind of the thought process, though. It was multifaceted, but that's part of it. At least that's the orthopedic part.
T.J. Samson Not-for-Profit Corporation recently floated a $30 million municipal bond issue. That money is being used to capitalize a for-profit corporation, T.J. Partners. How can money borrowed under one umbrella be used for another different entity?